Okay, thanks. Hi, everyone. My name's Zach Davis. I'm one of the second-year ophthalmology residents. My grand rounds is called Pucker Up. And I just want to thank Dr. Carrier for being my mentor. Here's the accreditation slides, no disclosures. Okay, so my patient is a 70-year-old Caucasian male who, with a chief complaint, when he looks to the right, when he looks with his right eye, things look crooked. So for 2 months, he said that objects looked bent in his right eye. He first noticed it when looking at a tree in his backyard, and it looked like it was bent, and he actually walked over to make sure it wasn't bent, which is metamorphopsia. And he said it's stable over that time. He has one tree in his backyard. He looks at it every day to to see if it changes. So he said there's possibly a small degree of decrease in visual acuity over that period of time, maybe a little worsening glare at night. He has one floater which is stable, and he denies any flashing lights, increase in floaters, curtains, eye pain, double vision, trauma, macropsia or micropsia, and or changes in the left eye or changes in health over that period of time. Here's my artistic rendition of what he was experiencing. Just quick for the first years, can anyone give me a differential diagnosis for metamorphopsia?
Macular degeneration.
Great, yep, so that would be one. Can anyone give me one more?
Like a macular hole, maybe?
Yeah, macular hole. So essentially, just the major causes, age-related macular degeneration, CSCR, anything that's going to disrupt the fovea can cause metamorphopsia. And if that's a monocular, if it's binocular, you got to think of a visual cortex, a stroke, or a migraine. Very good. Continuing, his HPI, he's got some atherosclerotic risk factors. His past ocular history is MGD. He has non-visually significant cataracts. The year before in his right eye, he best corrected to 20/30, and we couldn't get a cataract out of him yet. He's on some medications for hypertension, hyperlipidemia, social history, smokes cigarettes, just a few cigarettes a week, and denied any allergies. So his exams, pupils were normal, confrontation visual fields full, extraocular motions full, and ortho and primary. Pressures were good. In his right eye's vision decreased a little bit. He is 20/50 now and pinhole to 20/40 -2. And left eye was unchanged from the previous year, 20/40, and pinhole to 20/25. So I gave him an Amsler grid, and in the right eye, he said there weren't any missing bars, but they were bent and wavy. And the left eye, everything looked as it should, square and line straight. So, for his exam, he had meibomian gland disease, and he had some small tear debris in his tear film. But other than that, he had a 2 to 3 plus nuclear sclerotic cataract, and he had PVDs in both eyes. So here's some fundus photos. If we have a first year volunteer to read them or describe them.
Yeah, I can give it a shot. So we're looking at color fundus photos of the patient's eyes. On the left photo, we see media looks clear, optic disc has sharp margins, although maybe a bit temporally, it seems a bit less sharp. The macula has an area superior to it, almost like a white fluffy infiltrate, and possibly some drusen temporal to that. The vessels look normal. In the right photo, again, macula or the media looks clear. Nerve has sharp margins. Macula, again, a bit more nasally, shows these similar white fluffy infiltrates, and the vessels appear normal.
Okay, thanks, Kaushik. I appreciate you volunteering as well. So the first thing I want to bring up is, because see that white fluffy infiltrate, that because if you notice it's the same shape in both pictures, that's an artifact from the camera. But other than that, so in the disc, there's a little peripapillar atrophy temporally, and it's really hard to appreciate with these fundus photos. But there's actually an atypical sheen, especially in the right eye. And if you look closely, there's some distortion of the vessels. They're a little tortuous and wrinkly. And you can actually see some striae in the retina there. So overall, it's a good job, Kaushik. So he had PVDs in both eyes, as mentioned. The vasculature, there's normal caliber crossings. There's distorted fine retinal vessels in the macula in the right eye. It was kind of hard to appreciate in the color fundus photo, but in real life there was a gray-white translucent epiretinal membrane, kind of obscured and distorted retinal vessels of fine retinal vessels in the macula, with multiple interretinal striae. There was a kind of a glistening, broader, larger light reflex, and in the left eye there was a slightly abnormal, maybe slightly glistening foveal light reflex. There's nothing notable in the periphery. So the OCT, if we could have a second year to take a crack at the OCT.
All right. So the right eye definitely has temporal macular swelling. If you look at the cross section, you see an epiretinal membrane. Like if it's that bright line above the RNFL. The right eye looks good. No macular edema. Good fovea contour. Yeah. Left eye or the right eye, the fovea contour is disrupted by the ERM.
Yep. So thanks, Ben. I appreciate it. I was about to break there and just describe it myself. Thank you very much. Yeah. So in the right eye, there's foveal thickening, loss of foveal contour. You can see the hyperreflectivity of the epiretinal membrane, and you can see that in the fovea, the IS-OS junction is slightly anteriorly displaced. Whereas in the left eye, there's also retinal membrane, but the foveal architecture, the foveal contour is preserved, and the foveal architecture is not disrupted. So yeah, so that's pretty much what I wrote here. There's no evidence of vitreomacular traction. No view of the posterior hyaloid there, and yep, that's pretty much where we're at there. So okay, so this patient has an epiretinal membrane, or had an epiretinal membrane, and so it's a condition of many names. So first, let's review the nomenclature. So the epiretinal membrane or preretinal membrane is a generic term, and they're kind of named afterwards based on whether they're simple or complex. So if they're simple, they're non-contractile, they're not going to affect the vision. It's referred to as cellophane maculopathy, and that's where you're going to see that the abnormal glistening foveal light reflex. Whereas the complex epiretinal membranes, you're going to see striae, folds, you're going to see visual symptoms. That's what you're going to refer to as macular pucker, surface wrinkling retinopathy, preretinal fibrosis, preretinal gliosis, macular fibrosis, or macular gliosis. So just a brief introduction. The symptoms are largely determined by the thickness of the epiretinal membrane and the degree of contracture. So as we said earlier, cellophane maculopathy, no real distortion, no real symptoms. Whereas complex, you're going to get a thicker membrane and get those kind of distortions. So the clinical characteristics, can vary widely based on how the fovea is distorted, and also how thick that membrane is. So in these pictures in the pictures on the right, you can see picture A, just illustrating that you can, with the cellophane maculopathy, sometimes it can be difficult to appreciate. So using a red-free light, it will highlight the epiretinal membrane. In the picture B, you'll see this is a macular pucker, where you'll see a fine distortion of the fine retinal vessels there, and that's kind of you can see that in our patient. And in picture C and D, those are advanced epiretinal membranes. You're going to see marked wrinkling in striae in C, and in D, you'll see there's a picture of a pseudo hole. So back to our case, I kind of zoomed in here, and you can kind of appreciate that the distortion of the blood vessels, and also you can see the striae in the retina a little better when it's zoomed in. So epiretinal membranes, what is it? What's the definition? The definition is an avascular fibrocellular membrane that proliferates in the inner surface of the retina and produces various degrees of macular dysfunction. We classify these as either primary or secondary. Primary meaning primary or idiopathic. And secondary, associated with retinal breaks, post-intraocular surgery, trauma, inflammation, laser, long-standing inflammation, and vitreous hemorrhage. So the objectives for the rest of this presentation are to review the epidemiology, the pathogenesis, and quickly review the diagnostics, ancillary testing, and the treatments and outcomes. So as far as epidemiology goes, on autopsy studies, 2% of people older 50 years old have epiretinal membranes, whereas in 70-year-olds, 20% have epiretinal membranes. In the United States, Hispanics have the greatest predilection for developing epiretinal membranes, followed by whites and blacks. And however, one study in China showed that I think like 30% of people over 70 had them. So Chinese people in China might have a greater predilection. As far as race, two of the resources I used said that females were more prevalent than males, but the BCSC says males equal females. So when it comes to OCAPs, there is no gender. The genders are equally represented. So as far as idiopathic, if you diagnose epiretinal membrane in one eye, there 13.5% of people will develop a second epiretinal membrane in their other eye within 5 years, and 20 to 30% of people will develop an epiretinal membrane in their second eye during their lifetime. It's important to know though that it's extremely uncommon to have significant visual alterations in both eyes, and the disease process is almost always asymmetric if you're gonna have bilateral involvement. Some interesting statistics are that after a regnitogenous retinal detachment repair, 4 to 8% of people will develop a symptomatic secondary epiretinal membrane, and after lasering retinal breaks, 1 to 2% of people will go on to develop a symptomatic epiretinal membrane at some point in their lifetime. So as far as pathogenesis goes, there's idiopathic and there's secondary. In idiopathic, posterior vitreous detachment is the key finding that kind of sets up the whole process. Originally, the studies investigating epiretinal membranes were using biomicroscopy to identify whether there's a PVD, and those big studies show that 90% of patients had a PVD. However, later, more recent studies utilizing OCT have kind of found that there's essentially always a partial or perifoveal PVD present in idiopathic epiretinal membranes. So in the pathogenesis, there's 5 major cell types that are associated with the development of epiretinal membranes. But the complicating part about these studies are that these cells have an ability to transform and show cell markers of the other cell types. So if you're trying to find microglia, any of these cells might have the cell markers for microglia at a certain period of time in an epiretinal membrane process. So essentially, when they remove epiretinal membranes and they look at surgical samples and pathologists look at them, they're fibrocellular sheets containing native vitreous, newly synthesized collagen, and fragments of ILM. So we're going to go more on to idiopathic pathogenesis in a little while, but as far as retinal breaks go, when you have a retinal break, RPE cells are liberated into the vitreous, and that's kind of when we talk about tobacco dust. Those RPE cells make their way to the ILM, and then they kind of form contractile membrane surface, and it's a similar process to PVR. Whereas in secondary secondary processes involve vitreous inflammation and breakdown of the retina blood barrier, and these cytokines that are released stimulate cellular proliferation and metaplasia. So Dr. Gross published a paper in Retina Specialist in 2018 that kind of reviewed the 3 major theories behind epiretinal membrane pathogenesis, and we're going to go over those right now. So the first theory is that microglial cells can migrate. So it starts with the PVD, and all these theories are going to start with the PVD. Then you're going to get micro breaks in the ILM, and microglial cells will migrate from posterior to the ILM to anterior and superficial to it, and they'll spread over the surface and differentiate into fibroglial cells. They'll proliferate, and then they'll contract. The migration causes anchorage of the ILM to the underlying retina, and that's kind of the underlying cause of the contraction of the striae. So here's over on the right here, you can see a histology slide where the black and the arrows and the blue arrows are pictures of fibroglia that have kind of contorted themselves, and the red arrows point to an opening in the ILM. So why do we not like this theory? Well, we don't really see these holes often. And there's kind of this ad hoc explanation that says, well, the holes close after the cells migrate through. So there's some good evidence, but there's also some problems with this. Theory number 2, segments of the cellular vitreous remain on the retinal surface. So once again, we have the PVD, and segments of the vitreous remain on the retinal surface. So synchesis is liquidification of the vitreous, and without concurrent vitreoretinal dehiscence. So the most posterior vitreous will remain attached to the retina, to the ILM, and so during separation, some of the vitreous will get left behind. Hyalinocytes in the vitreous are left on the ILM, and they'll metaplase into myofibroblasts. So why is this? Why do we like this theory? Well, vitreoschisis exists and is present pretty often, and the contractile abilities and presence of the myofibroblasts isn't debated at all. We don't like this theory because there's been multiple studies that have looked at that have examined areas of the retina where epiretinal membranes have formed later on, and there were no vitreous cells there present after the PVD. So we have areas where it's unlikely that vitreous is later going to migrate to, and that later form PVDs. I mean, that later form ERMs. So the third theory is avulsion defects. So the ILM is the thinnest anatomically. It's thinner in the retina and the retinal vessels in the posterior pole. And so when a PVD happens, the ILM adjacent to the retinal vessels avulses during separation, and this causes an upregulation of cytokines and an inflammatory response, secondary to what you'll see in some secondary ERM processes. And then you'll develop metaplasia and change in organization of the cells that lead to epiretinal membrane formation. So why do we like this theory? There's no so during when you're going to do an ILM peel, you can use ICG, which we'll talk about in a little while. But the ICG doesn't stain along the perivascular arcades during epiretinal membrane surgery. This has been widely noted by many retinal surgeons. So why don't we like this? Well, the thought is that maybe the ICG just doesn't stain there, but while the ILM is present. So just because we're using the ICG staining to be equivocal to be equivocal to the ILM being present, that's not necessarily true. So in histology and pathology, the ILM present in those areas where it's really thin, and notably in the arcades, the ILM doesn't stain with a lot of conventional stains in those areas. So maybe it's anatomically different, or maybe there's just not maybe it's the thinness of it precludes it from picking up the stain. And so just so we're not actually sure the ILM isn't present there, or it's actually getting avulsed. So that's the problem with theory number 3. So in summary, there's lots of questions about that are remaining about the ERM pathogenesis, and we pretty much went over all of them. But what we do know is that a PVD is pretty much always present. The cells from the vitreous and/or cells from the retina make their way to the ILM and proliferate across and develop contractile properties, and this disrupts the vision. So let's now talk quickly about the pathophysiology of the vision changes. So for metamorphopsia, we're getting a distortion of the retinal architecture, and we're getting displacement of the foveal cones. This is the same underlying pathology or pathophysiology of any cause of metamorphopsia. Sometimes you'll see, interestingly, binocular diplopia, and this happens with foveal ectopia. Essentially, when you have a non-central ERM, you're going to get lateral displacement of the fovea without detachment from the RPE. And macropsia can also occur, and this occurs when you have retinal traction and thickening of the of the internuclear layer. You can develop crowding of photoreceptors in the fovea. So, but those are kind of visual phenomena. But epiretinal membranes themselves can cause vision loss, and this is also a pretty poorly understood and researched topic. So some of the ideas are that there's a filtering effect on the membrane on the photoreceptors. So maybe not all the light actually gets to the photoreceptors because they have to pass through the epiretinal membrane. There's also thought that there's an obstruction of axoplasmic flow of the RNFL, and they've shown that actually the obstruction of the axoplasmic flow is responsible for the whitening that you see in a lot of epiretinal membranes. Other causes are intraretinal edema and alterations to the macular blood flow. recent studies have turned towards ERG and multifocal ERG in order to investigate this. So the outcome of these studies are that the dysfunction may actually be more associated with the Mueller, may be more associated and start with dysfunction of the Mueller and bipolar cells compared to the photoreceptors. So just as a quick review, there's an A wave and a B wave in ERG, and the A wave represents the action of the photoreceptors, whereas the B wave represents the action of the Mueller cells and bipolar cells, and is also dependent on the photoreceptors, obviously. So in one study, multifocal ERG showed that more B wave abnormalities in patients with epiretinal membrane than A wave abnormalities. And in surgical cases, P1, which is analogous to the B wave, is more predictive of the final visual outcome than the N1 responses. So what they're saying is dysfunction in the bipolar and Mueller cells has better surgical prognosis, has worse surgical prognosis dysfunction there than with the cones and rods themselves. So now I'll quickly go over to diagnostic and ancillary testing. So this is a clinical diagnosis, and it's made by biomicroscopy with our, with the slit lamp with our 90s or our indirects. They recommend using contact lens biomicroscopy for subtle ERMs when there's ocular surface disease or when there's media opacities. They also recommend red-free or green light is going to allow you to better visualize them. Fluorescein angiography is useful for media opacities. If there's CME and you're trying to distinguish between other patterns such as Irvine gas, if there's pseudo holes versus full holes, and rule out other maculopathies. And OCT is the mainstay in pretty much every retinal condition. And you're going to see that hyperreflective membrane anteriorly. You look at also identify vitreomacular traction, pseudo holes, the ISOS status, and visual prognosis for surgery. So for treatments and outcomes, if the epiretinal membrane is asymptomatic, you should just observe. There have been several studies that have looked at progression, and in more advanced and mild, self-limiting maculopathies to macular puckers. And essentially, the most of the time, the way it works is the epiretinal membrane will form and then quickly contract, and then it'll stabilize and pretty much not change afterwards. Rarely, the epiretinal membrane can separate spontaneously, and the symptoms will actually resolve completely. That's not really completely understood, and we're not actually sure why that happens so rarely. And also, but if there is vision loss or metamorphopsia, it's recommended to do a vitrectomy and an epiretinal membrane peel. So some people like to do an ILM peel, but that's with the epiretinal membrane peel, which is controversial because the ILM acts as a scaffold for the cells that cause the epiretinal membrane to kind of climb across and contract over. And so by removing the ILM, you can prevent rates of reoccurrence, and this has been widely established. However, ILM peel has never been demonstrated to have a visual benefit. When doing an ILM peel, you have to use vital dyes like ICG, trypan blue, brilliant blue, but ICG toxicity is a major concern. And in studies, different concentrations and different protocols with ICG are used pretty much in all the studies, and so there's really not a good consensus on what's appropriate and what's not appropriate, and it's kind of a surgical and experience preference. But who are the best candidates for surgery? So the people do best if they've had symptoms for less than 1 year, if there's no TRD or CME, if their vision is better than 2100. When people have worse vision, they'll actually have more improvement, but overall they'll have more improvement and they'll improve more lines in the Snellen chart, but overall they'll have worse outcomes. OCT, having an intact ISOS, less foveal thickening, and a thinner ganglion cell and IPL layer is associated with better outcomes. Notable, the fluorescein angiography test has never been shown to have any prognostic value. And for multifocal ERGs, shorter P1 times that B wave has been shown to have better visual outcomes. So overall, 75% of patients will have improved visual acuity, and the vision doesn't improve over a day or a month. Usually, it takes 6 months to a year. And what most retinal surgeons will say is that you'll get halfway to normal. So so if your vision baseline was 20/20 and you were 24 and your vision's now 20/40, you would get to 20. You could potentially get to 20/30. People generally won't operate unless the vision is significant is worse than that. But sometimes if they're having metamorphopsia, you might elect to do an epiretinal membrane at that point. So 10 to 25% of people's vision will decline over days to years afterwards. The OCT, just quickly, I just wanted to reiterate that the OCT will will never go back to normal. So it will always show some degree of persistent thickening, and the M and on multifocal ERG, the oscillatory potentials of the A and B waves more normalized, but they never go back to normal. So even after you do a membrane peel, the vision, patients will say the vision kind of never goes back to normal, and this kind of correlates to anatomically it never really going back to the way it was. So these are my references, and I just want to say thanks for all listening, and do you guys have any questions?
That was a good presentation, Zach. This is Dr. Reynoso. So, I'll say with ICG, you can't really stain ERMs. ERMs won't stain with ICG. So it's not just that the perivascular areas don't stain that great. It's just whenever you have an ERM, you can't really stain an ERM with ICG. So basically, you have to peel the ERM first, then get ICG into stain ILM. So ICG really just stains ILM. I do ILM peels after ERMs, and again, not necessarily to make the vision better, but just to decrease the risk of recurrence. With ERM peels, I'm a little bit less worried about ICG toxicity. I'm usually more concerned about it with macular holes, because then the ICG can actually get towards the RPE. But I'm not super concerned with ERMs, because ICG won't get to the RPE. And one thing to keep in mind is, you always have to evaluate the ellipsoid line before doing your ERM peel, because that has been shown to correlate with the vision that you'll get after ERM peel. So if the ellipsoid line is disrupted on your OCT, you may not get much better vision. Also, if it's, an ERM that's chronic and you've had a lot of swelling for a long time, the damage to the photoreceptors may have already been done. So important to discuss that with patients as well, that you don't know what the vision will be after ERM peel.
Thank you.
All righty, so if there are no other comments, let's go ahead with the next case.
Are you able to see my screen?
Yes.
Okay. All right. So my presentation is titled Painful Vision Loss in a 29-year-old Male Prisoner. I'd just like to thank Dr. Hall and Dr. Connolly for their help with the presentation and when we were seeing this patient. Target audience, just standard slides. Disclosure. Okay. So the chief complaint of this patient was, my left eye hurts and I can't see at all out of it. Just more about his history. As I mentioned, he's 29 years old. He has a history of hydrocephalus, and basically 2 months ago, before presentation, he says he woke up in severe pain out of that left eye and that he had complete vision loss. He also said that he had a blue bump on his eye surface that was getting bigger. Just more details about the pain. He described it as drill-like. Those are the words he used in nature. He also experienced some tearing, significant light sensitivity, redness throughout his eye as well. This is all in the left eye. The right eye, he felt, had no problems whatsoever. He couldn't think of any precipitating causes for why this happened. He didn't get hit in the eye. He didn't get sick recently before. This really sort of came out of the blue. And he was seen at St. Martin Hospital in Brewbridge at the time. He was taken from prison to the hospital. He was diagnosed with pink eye and was just given some eye drops. It's not clear what exactly those drops were, but he took them for a couple weeks. No improvement. Went back to prison. And on the 12th, somebody saw him and said that his eye lesion looked worse and worse. So keep in mind, this is almost 2 months that he was sitting on this with just some eye drops that was given for pink eye. So he was transferred then to the UHC ED. They gave him some Toradol, which helped his pain a little bit, but that's when we saw him. So his examination on the right is largely normal. The left, though, is more concerning. He was count fingers in his vision on presentation. His pupils were not reactive. It seemed like it was supranasally peaked. We did assess for an APD by reverse. As far as I could tell, I did not see that. Extraocular movements were intact. His visual fields were full to hand motion. Cranial nerves were intact. His pressures were 12 on the right and 5 on the left. The remainder of his exam, so he had some left upper lid edema on the, left upper lid edema. His conjugate sclera revealed chemosis. He had injection of that eye. There was an area of thinning supranasally located, and it looked like a staphyloma bulging out. We did stain him. Didn't seem like there was any signs of leak. His cornea was remarkable for a significant amount of mutton fat KP, just spread all across the endothelium. And in addition to that, he had significant cell and flare. I mentioned the iris and the pupil before, and he had a bit of a early cataract formation in vitreous haze. The right eye was unremarkable. Lastly, for his DFE, the main thing in both eyes was that he had an elevated cup to disc ratio of 0.65. He did mention that maybe he thought he heard somewhere that someone told him he had glaucoma, but there was no diagnosis that we saw anywhere formally made. And some of our views on the left were unfortunately limited at the time. We did do a B scan that didn't show any signs of scleral thickening, T sign, which I'll talk about a bit later, no signs of detachment. So if anyone's willing to take a stab at what they're seeing here. Oops.
Jack?
Sure. So this is an external photo of the eye. You can see there's some injection, like +1 to +2 injection of the conj. Kind of superior nasally, maybe I guess like kind of that 10 to approaching 12 o'clock. There is this kind of oval shaped blue protrusion kind of above the, I guess, the limbus there. Kind of hard to see like at the rest of the details of like the cornea or the AC or anything else, but just kind of obviously the most noticeable thing is that kind of bluish mass.
Right. That's yeah. In fact, when we got called by the ED physician told me he was saying the patient might have had cancer, and then this is what he was referring to. And as you can see, it's barely covered by the thinnest layer of conjunctiva. But yeah, thanks, Jack. Okay, so what are some diagnoses? What's on the differential diagnosis for what we're seeing here? Anyone can jump in.
Necrotizing
Uveitis, scleromalacia perforans,
Mm-hmm.
due to uveitis.
Sarcoidosis.
Yeah.
Versus granulomatosis.
Mm-hmm. Yep. Those are all key considerations, especially I'm glad some of you mentioned some of those systemic diseases, because that's something we're definitely going to go into. But yeah, painful red eye can be a number of things, either just some of them. In this case, we made the diagnosis of granulomatous necrotizing scleritis with inflammation. And that was based on the clinical scenario of what he came in with, the vision loss, the degree of inflammation inside the eye, especially that staphyloma, that area of significant thinning in the sclera supranasally with bulging uvea. So that's the topic of my presentation. We're going to discuss scleritis. There are different ways of organizing it. I just use what the BCSC did just for the sake of consistency, but this isn't the only way to kind of categorize it. Basically, the most common form is anterior, and that's defined as scleral inflammation that's anterior to the extraocular recti muscles. You also have posterior, which is only 6% of cases. Within anterior, there's 3 subcategories: diffuse, necrotizing, and nodular. You can see the corresponding percentages of prevalence for each of those categories. And within necrotizing, we have with inflammation and without inflammation. So we're just going to briefly go over each of these topics and discuss management or diagnosis management for scleritis. Before I do that, though, actually, I think it's worth kind of going over the sclera and the anatomy of the sclera. So basically, you have the stroma of the sclera. That's the deepest layer. Above that, you have the episclera, and above that, you have the conjunctiva. The sclera mostly is collagen type 1, and you have these, it has additional layers inside it. But the thing I want to point out are these 3 vascular plexus. They supply the outer layers of the eye, including the conjunctiva, the episclera. There's no vessels in the stroma itself, though. In the stroma proper, there's no vessels. But in a patient with conjunctivitis, you're going to see inflammation of that conjunctival plexus. With episcleritis, you'll see the superficial episcleral plexus become inflamed. But in scleritis, there's inflammation of the deep vascular plexus. So it's not that when you're talking about scleritis and the red that you're sort of seeing in the eye, it's not like there's inflammation. There's not vessels that are becoming inflamed in the stroma. It's technically actually in the episclera, but just deep. This is a little chart I pulled up, just kind of to keep in mind the differences. Again, the conjunctival plexus is most superficial. When it is inflamed, you will notice kind of tortuous arteries. The veins might be straight. You can easily manipulate it. So if you took a cotton tip and rubbed it against the conjunctiva, you would be able to move those vessels. If it's inflamed, it would be bright red. And typically, our classic conjunctivitis is like bacterial viral conjunctivitis. That's what you would see. The superficial episcleral plexus is at the level of tenons. When inflamed, the arteries take on a radial appearance, and they're straight as opposed to the tortuous arterioles of the conjunctival plexus. You can manipulate a little bit, but you would still see underneath that some vessels. It's not the most anterior layer of vessels. When inflamed, it's noted to have a kind of salmon pink appearance, and this is what you would see with episcleritis. And what we're talking about in this presentation is inflammation of the deep vascular plexus. That's what overlies the scleral stroma. The vessels take on a kind of crisscross appearance when inflamed. You cannot move these vessels if you try to manipulate them. And it has a characteristic violaceous hue. I don't know if that's, I don't know, I mean, some of the pictures I've seen, I don't feel like that's always the case, but that's sort of the textbook difference, and that's what we see in scleritis. Okay, so the pathogenesis for scleritis, it depends on these different subtypes that I came across, but in general, you're thinking it's an immune-mediated vasculitis. It frequently leads to destruction of the sclera. There are a variety of immune cells involved, specifically all kinds of T cells and macrophages that are involved in the inflammation process. Plasma cells are responsible for recruiting IL-2 and metalloproteases and TNF-alpha. And a combination of these processes is what results in the inflammation and possible necrosis of scleral tissue. One of the most important things to bear in mind is the association of scleritis with systemic immunological disease. And some of the biggest culprits that you'll see are rheumatoid arthritis, lupus, sarcoidosis, the seronegative spondyloarthropathies. Those are frequently associated in patients with patients who have scleritis. About a third of patients who have diffuse or nodular scleritis have some kind of systemic association, whereas 2/3 of those who have necrotizing scleritis will have a systemic association. So it's more common in that. You can also see granulomatous inflammation or non-granulomatous inflammation. Typically, if it's idiopathic scleritis, there's no, if there's no association. It tends to be non-granulomatous in nature, but in cases of autoimmune scleritis, you're more likely to see the granulomatous inflammation. And kind of like in what we saw in our patient earlier, we saw things like the mutton fat KP, which was more suggestive of granulomatous. So a bit more about how patients with scleritis present. Generally, it presents in middle age, 4th to 6th decade. You will see it more in women compared to men, but that is with the caveat that, again, certain subtypes will have predilection for males, but in general, it tends to be more seen in males, and half of the cases are bilateral. As far as the actual diagnosis is concerned, it is a clinical diagnosis. And one of the characteristic symptoms is the boring ocular pain. As I said before, our patient woke up with, you described it as a drool-like pain. And kind of the textbook situation is a patient wakes up in this severe pain. And that's actually what we saw with him. And the globe will be very tender to palpation. You can have vision loss. It's more common to see vision loss in cases of necrotizing scleritis. And again, you also want to pay attention to non-ocular symptoms. So if we're thinking, in the back of our head, we have to keep in mind things like rheumatoid arthritis. So we're wondering, does the patient have, arthritis or skin nodules? We're thinking about maybe lupus. Do they have a malar rash? So things we have to ask the patient about what symptoms they're having beyond just the eye, because that could clue us in as to what the broader diagnosis is. In terms of signs, you're going to have scleral edema, and that kind of stretching of the sclera is actually one of the big reasons why patients experience the degree of pain that they do. There is this violaceous inflammation, sort of what I was alluding to before in that chart, and vessel dilation. In the anterior segment, you can find keratitis, you can have corneal thinning, uveitis. We were seeing evidence of that. And if it extends posteriorly, you can see retinal vasculitis, chorioretinal granulomas. You can even get retinal detachments, but that's less common. Okay, so now we're just going to move on to the different types of anterior scleritis. So diffuse scleritis, it's pretty self-explanatory. It actually doesn't have to necessarily cover the entire globe, but it must be flat, and it can't have a raised appearance. It's characterized by both inflammation of the superficial and deep episcleral vessels. So both the plexuses of the episclera. And it only really involves the entire anterior segment in about 40% of cases. Nodular scleritis, it's characterized, as you might imagine, just by the presence of a nodule. It can be anywhere in the anterior portion of the eye, but it is very tender and it is immobile. So sometimes in scleritis or episcleritis, you can see nodules as well, but those are more likely to be mobile. Now we have necrotizing scleritis, which is, as you might imagine, the most destructive form. In about 2/3 of cases, there are systemic associations. The incidence of vision loss is extremely high. But beyond just the eyes, probably one of the most concerning aspects of necrotizing scleritis is that many of these patients have vasculitis complications. And so if these affect vital organs, if this affects the heart, it can be fatal. So actually identifying this kind of scleritis can give insight into the patient's overall health and possibly even allow you to take measures to help save their life. Okay, so within the necrotizing subtype, we have both with inflammation, and this is what we saw in our patient. Again, severe pain, you're going to have this localized area of inflammation, specifically close to the staphyloma, if you see one. That staphyloma is formed just from the scleral thinning, and you get this so-called choroidal show. It really can vary in terms of how much is apparent. if it gets to its extreme, I mean, you can end up just with the conjunctiva covering the staphyloma, and that's it. Unfortunately, this can extend to the posterior aspect of the eye as well, and cause posterior scleritis. This is an emergency. This needs to be treated immediately. And if it's not, you can lose function of the eye, and it can essentially destroy the eye if left to run amok. The other form of necrotizing scleritis is called scleromalacia perforans, or without inflammation. That's a bit of a misnomer. It's actually looking at the BCSC, is describing that while it's only called that because it looks like there's no inflammation, but it is mediated by inflammatory processes. So the classic signs like redness, like scleral edema, even pain, those are signs you wouldn't see in these kinds of patients. So it might confuse the diagnosis a bit, but it's something to be in mind, that you can have scleritis without pain or classic symptoms. But it can progress, given that it's necrotic, it can progress quite quickly and quite severely. Just regarding systemic associations, this in particular is seen a lot in cases of rheumatoid arthritis. Okay, so moving on to posterior scleritis, it's just its own kind of category. Relatively uncommon. By definition, it involves the sclera posterior to the insertion of the recti muscles. Symptoms, you're going to have pain. You might not see the redness as obviously, and some of the kind of visual symptoms or visual signs that you see on exam aren't as obvious. So in that sense, it might be more easily missed. But the patient's experiencing the photophobia, the pain, pain, especially with extraocular movements, is another key trait. This tends to have fewer of those systemic associations with rheumatologic conditions. Some of the signs you might see are choroidal folds, thickening. I had mentioned retinal detachment before, and that's going to happen, or that's more likely to happen if we have posterior segment involvement with scleritis. One other thing that's kind of a characteristic sign, kind of a buzzword, is the T sign, and that's fluid in the Tenon's capsule. And if someone wants to describe this photo, what they're seeing here.
John?
As a B scan, there's, let's see, looking around the optic nerve, there's a hypoechoic linear area abutting the optic nerve. Looks behind the area of the retina. I can't see the A scan, accompanying A scan beneath it.
Yeah, that's exactly right. So this is an example of T sign, which is the fluid behind Tenon's capsule, fluid in Tenon's capsule rather. And if you see that, that's suggesting to you that there is posterior scleritis involvement. Okay, so the workup is extensive. Given that it's largely rheumatological in origin, you kind of open up a can of worms, and it can be anything that's causing the scleritis. So you want to cover all your bases. There can be an infection. Some of the big culprits are syphilis and TB. You want to consider the vasculitides like Wegener's or polyarteritis nodosa. You need to complete a thorough physical exam and do pretty comprehensive lab work. And I mean, considering how much this spans, it's generally wise to involve colleagues from internal medicine and rheumatology, because this is beyond just an eye problem in many cases. So what are some of those tests? You often start with a chest X-ray. That's to help you find things that might be concerning, like in sarcoidosis, for example. You get basic blood work, inflammatory markers. You're looking for A-lysozyme against sarcoid. A ton of autoantibody screening tests to rule out some of those things like lupus or rheumatoid arthritis, ANCA. you can get urinalysis, you can get serum uric acid as well, because sometimes you can see this with gout. Syphilis is another important thing to realize. So you get syphilis serology, TB serology. I mean, if you look at the Wills manual, which we went by, it's a very comprehensive workup that you do for these patients. So as far as treatment is concerned, it must be systemic. You cannot treat scleritis with topical medications. That might work for episcleritis, but in this case, we're at a level that's so deep and so severe that you must use systemic treatments. If it's milder scleritis, if it's something like nodular or diffuse, you might be able to get away just with oral NSAIDs. You could do something like indomethacin 50 milligrams 3 times a day, or 600 milligrams of ibuprofen 3 times a day. And patients in remission may need to continue those oral steroids. But in cases of more severe scleritis, such as necrotizing, that's when you definitely need to move on to IV medications. Specifically, IV steroids are kind of the gold standard for treatment. You can do a pulse dosing of the steroids, so like 1,000 milligrams of Solumedrol for 3 days and then transition to oral steroids. If you decide to start with oral steroids, you typically do 1 milligram per kilogram per day for the patient, and you taper over the span of about 6 weeks. So you might start at like 60 to 80 milligrams and taper accordingly. If you're going the IV route, then eventually you will taper to the oral. And again, long-term remission might require steroids still, or just NSAIDs. It depends on what how the clinical course ensues. Beyond that, if none of these work, immunosuppressive therapies are the next line treatment. Some resources will suggest that for necrotizing scleritis, you should jump right ahead to immunosuppressive therapies, but as far as I am concerned, as far as I know, I don't think that's a universal standard, but some will jump directly to those. So anti-metabolite drugs, alkylating agents, biologics, things like methotrexate, mycophenolate, cyclosporin, tacrolimus, rituximab, TNF alpha inhibitors. There's a whole list of these agents that are kind of coming more to the forefront in terms of possible treatments for scleritis. Surgery is an option as well. There are 2 main indications for it. The surgery is a scleral patch. The first one is if there is significant thinning of the sclera and there's a high risk of rupture, that is an indication to do a graft. The other indication, which is a bit less common in these situations, is if there is significant astigmatism that is caused by the degree of the staphyloma growth, then that could also warrant surgery too. But the main thing is the risk of rupture. That's why you would really want to graft. And of course, eye shields. To me, it's kind of a miracle that that patient, when he presented, hadn't already perforated, because he was rubbing his eye all the time, even when we were treating him in the hospital. And just rubbing your eye can completely can worsen the clinical situation significantly, demanding surgery. So it's really important to make sure patients use eye shields as well, and ensure compliance with it too. Okay. As I mentioned, so the forefront of therapies nowadays are focusing on different immunosuppressive therapies. Probably of these, rituximab has gained the most steam. I've seen the most evidence for that. A few others are tofacitinib and tocilizumab, which has garnered more attention recently from COVID. But the latter 2, those are more in a few situations here and there. But really, of the different immunosuppressive therapies, rituximab is getting the most attention now, and there's things like methotrexate that are commonly used as well. Okay, so what are the complications of scleritis? Some of the bigger ones are anterior uveitis. You can get uveitis as a spillover phenomenon, just from the degree of inflammation of the sclera. And that's probably what we were seeing in our patient when we had that vitreous haze, those mutton fat KP. obviously the scleral thinning, which we've seen before in some of those photos. You can get peripheral ulcerative keratitis. You can get scleral keratitis, in which the peripheral cornea becomes opacified by fibrosis, by lipid deposition. And that actually might cover the entire cornea, so you can get vision loss that way as well. Herpes zoster in particular is associated with scleral keratitis. As far as how things are concerned for the patient's outlook, if it's mild to moderate, if you're having diffuse or nodular scleritis, there's a very good chance you'll have a complete visual recovery. Unfortunately, though, for necrotizing scleritis, the prognosis generally is poor. There will be some, if not tissue loss, some vision loss. And in the case of our unfortunate patient, he had gone 2 months without any treatment at all for this. So that made his prognosis even worse, unfortunately. But scleritis, despite the good prognosis, even in mild to moderate, it can take months to years for it to go into remission. And even then, patients will often need lifelong therapies to maintain remission. So it's something that the clinical course can really vary in terms of duration. I did want to also spend a couple minutes, it's not the focus of the presentation, but I think it's worth going over briefly, scleritis versus episcleritis, just because the two can look very similar. I alluded to this before with that chart I had made, but just to kind of briefly go over it.
Kaushik, sorry to interrupt. Are you almost done? Because we need a little time for questions as well.
Yeah, I think I have like one slide left.
Okay, sounds good.
Yeah. Yeah, just go over this quickly. Probably the biggest difference is that episcleritis will be non-granulomatous in nature, whereas scleritis can be both. When you're on exam, one of the easiest tests to do is adding phenylephrine. So because those layers of the plexus is more superficial in episclera, those vessels will constrict if you apply phenylephrine. Whereas in scleritis, those vessels are too deep, so they will not be affected by the phenylephrine you drop in. The vessels, as I mentioned before, are also immobile in scleritis and more mobile in episcleritis. So just some clinical clues to kind of help you figure how to distinguish the two. So yeah, just going back to our patient, we did that B scan, didn't show signs of posterior scleritis. He was admitted to the hospital. His chest x-ray showed a nodule, and a CT afterwards showed a 6 millimeter ground glass nodule in the left lower lobe. He was positive for Epstein-Barr virus, but the rest of his infectious workup came back negative. We did the Solumedrol pulse dosing for 3 days, and we put him on a prednisone taper. He did respond fairly well in terms of the inflammation, but we also had to added some IOP lowering agents for the according increase in his pressure. Rheumatology and infectious disease were all consulted, and we had left from Lafayette by the time the patient was discharged, but they've been following since then. The diagnosis of sarcoidosis was actually made based on that lung nodule. And it turned out, the patient didn't know this at first, but he brought his mom into one of the office visits, and she said that, yeah, she had a biopsy-proven sarcoidosis some years ago. So rheumatologist started on methotrexate in addition to the steroid taper. He's still seeing poorly. I don't know if he's gotten much beyond count fingers, but unfortunately, it seems like one of those cases where the scleritis has really done left its mark in its visual acuity. Just a quick summary of what we said, but I know we're short on time, so that's it.
So I think this is the same. Thank you for a detailed presentation. It sounds like the same person, and Dr. Bernal, if she's still on this, yeah, also had heard about, and I had heard about. So the loss, it is always important to know why someone's lost vision. This person did not have a posterior scleritis, but they did lose vision because part of this affected the cornea, if we're talking about the same patient.
Mm-hmm.
And when that's the case, you can get a huge amount of astigmatism or irregular astigmatism.
Right.
And this person had 12 diopters of astigmatism that could account for his loss of vision.
Mhm.
But I wanted to ask Dr. Bernal, is it not unusual to have do you think that sarcoid is the cause of this, or is that a red herring? Because a necrotizing scleritis with sarcoid seems to be pretty unusual. Or have you seen this before?
Yes, no, it's not that unusual. It's definitely part of the differential diagnosis. Sarcoidosis can cause a lot of different inflammation in the eyes, but it's been seen. I just wanted to a few comments regarding the presentation. It's a really good presentation. Just keep in mind that when you see these patients, like Kaushik said, you have to think about an underlying systemic vasculitis. So extremely important to treat that. I know when we see that, the first thing we want to do is, well, let's go take this patient to surgery and put a patch graft. But you cannot, if you're going to do any surgery with an active inflammation, it's just going to melt and fail. It's going to be a disaster. So you definitely have to make sure these patients are quiet. I don't think every patient has to be on IV sodium medrol. Necrotizing scleritis, once you rule out infectious, then yes, you can do that, but you have to be working right there with the rheumatologist. Make sure you rule all the other, you have to, because you have to start IMT ASAP. If it's not a necrotizing scleritis, you can definitely start them on, like you said, NSAIDs. If that doesn't work, then you do PO prednisone. If you do PO prednisone, then do the 1 milligram per kilo per day. You don't have to really go above 60 milligrams. That's a plenty immunosuppressive dose, even if they're a little bit more than that as far as weight. But if the patient is not a lot better in 2 weeks, you really have to consider if this is an infectious cause or something else causing this. But you have to taper the prednisone and start on some IMT. But it doesn't take that long to get it under control. They will have to be on some sort of medication, IMT, for a long time, but you should be able to see some response pretty soon. If not, then you have to jump to biologicals and things like that.
Now, I don't know if this is a case with, this might actually, if you got some good photos, be worth submitting somewhere, because when I go on PubMed, I don't see a whole bunch written on necrotizing scleritises and sarcoid. But now, what was the point of what I was going to make? I have no idea what point I was going to make, so I guess it really isn't. Oh, the point I was going to make is with rheumatoid arthritis. As Dr. Bernal said, this is a systemic disease. So with rheumatoid arthritis, by the time someone gets into a scleromalacia perforans, they have a higher mortality rate because it doesn't just reflect what's going on in the eye, it reflects what's going on systemically. I don't know if it's the same case here. Maria, from your experience with such patients, do you think it's just confined to the eye, or do you think this bodes poorly systemically as well?
I think it's, like you said, it's pretty much the same as rheumatoid arthritis. So you have to assume there's an underlying systemic vasculitis.
Yeah, and that's one of the things that Dr. Hall mentioned. Like one of the first things he said is one of these patients, you have to check for vasculitis because that can kill them. And in this patient's workup, earlier on we were thinking Wegener's might have been the diagnosis, but really ANCA came back negative. Really, like I said, all the inflammatory markers and kind of the screening measures we use for some of these diseases came back negative, which was a little surprising to us, but absolutely, it doesn't mean that it's not there.
So Maria, you've seen people with this level of melt with sarcoid?
I don't have had any patients like this specifically, but remember, sarcoidosis can cause horrible CNS vasculitis. Myocarditis. Any organ in the system, in your system, can be inflamed pretty much by sarcoidosis, and they're can be pretty aggressive cases. As far as I know, yeah, that has been described.
Because I don't see much in PubMed, so I'm just, if anyone finds any stuff in PubMed, please let me know, because I'm not seeing a lot there specifically about this level of melt in sarcoid.
Yeah, but if you don't find any papers, then maybe it would be worth thinking about publishing it.
Yeah, just on, a 3-minute search previously didn't show me anything. There is a large review article on sarcoidosis where they talk about the eye findings, but I'm not, as I said, I'm not finding that. We do have a little bit of photos on this person, and I think he looks like he has progressed some, and there's some question about doing a surgical procedure on him.
Yeah, he was referred to someone
Rouge.
yeah. Can't remember the name, but yeah.
Yeah, but it is important if someone has decreased vision, regardless of what is associated, you really want to understand why, because understanding the cause of the decreased vision is what revealed to the examining person that the issue here also was corneal thinning, that this had gone into the cornea. So Weiss's rule, always understand why someone can't see.
Right.
Okay, nice presentation. Thank you.
Thank you.
All right, thank you all. Do you guys have a question session?
Yeah, we
All
do.
right. All righty. Actually, I'm not really sure how you guys did last Wednesday, but I'll find out and let you guys know. Thank you for turning your cameras on. I'm actually in clinic, so I don't have a camera, but I will turn my camera on next time. Have a good one.
All right, guys, I'm gonna send out the link for the question session, and I'll give everybody, I just sent it now, so I'll give everybody oh, sorry, Matt. I'll give everybody 8 minutes. You can unmute it and turn off the video, and I'll sign on here.